Thank you. And I'm going to talk about double row, when you should use it or could use it and make it cost effective, and I'll show you some steps for success. My typical double row is when the tear is mobile and reducible. I'm going to use medium tears as an example with one single anchor medially and one laterally and using the 6 limbs. I don't tie medial knots. I use lateral screw-in anchors because push-in anchors can pull out. I use this for up to 3 to 3.5 centimeter tears, and it's been evolving since I started in 2013. But I don't hesitate if there's a tear that with release is not reducible or has poor tendon or bone to do a single row repair, and I do like bone vents. So my goal for today is for you to come away with a couple ideas and techniques to use a couple times over the next few months to improve your craft as a shoulder surgeon. What's the scientific basis of my technique? 2 things: the number of sutures, and Buddy told me this about 15 years ago, and then Scott Rodeo in his lab confirmed it's the number of sutures, not the number of anchors. And as far as suture placement, how medial should they be? Brian Cole and his group showed this. They published it for double row, but when he and I spoke about it, it's obviously good for any row. The more medial you pass your sutures, the greater resistance to pull out. So some of my steps. I like to prepare the greater tuberosity through the sulcus. That allows us to get more posterior medially. And as I tell the residents, how you prepare is as important as how you repair. Also, I release the middle glenohumeral ligament in almost all the cases. I guess I'm a MGHL killer. And I like to go through the cuff tear, as I mentioned, when there's no glenohumeral work below the mid-glenoid. And this way I can establish my anterior portal later. So this is the example I'm going to use throughout the talk. So with releases, this isn't enough. It's got to be reducible to the lateral edge for this type of a technique. I'll place my medial anchor about central to the tear. I like using a straight punch because sometimes the bone isn't as good, and I don't like a wedge. But if the bone is really good, you can tap it, and I like solid screw-in anchors. And that gives me 6 limbs. Suture passage, I use retrograde techniques. You always want to know where the anterior aspect of the supraspinatus is. And I always view from the 50-yard line, so to speak. This is one shuttling technique with a 0 proline. And I do that from anterior, and then as I go further posterior, there's many different penetrating devices, and if you have a good assistant, they'll help deliver the tendon for you so that you know where you can pass. And in this case, here are your sutures all passed, lateral to the muscle tendon junction, medial to the cable. So this is our sutures in our patient. I just want to point out one thing, and that's why I love this course. In 2017, Butch Krishnan showed me about using one of your sutures for your cuff repair through your biceps, and I use that a lot now. And that's this suture now anterior to the supraspinatus with good bites. Another thing that is helpful along the way is an oblique side-to-side suture to reduce the tear. In this particular patient, you can come percutaneous posterolateral with a spinal needle. You can go across the tear in an oblique fashion and then tie it down, and it reduces your tear laterally. So this is our patient we've been referring to, and all you need to do is put the tendon down. Before I switch, I'll mark 7 to 10 millimeters placement. I'll abduct the arm. This allows me to be perpendicular to the greater tuberosity, and now we're viewing from posterior. I'll retrieve the sutures, pass them into the device, bring them in. If I use a 5.5 laterally, but if the bone is any question, I'll use a 6.5 screw-in anchor. So in another patient, just to show you how it's reduced, you always insert, then you tension, and get good compression onto the prepared bony bed. Then the anchor goes down. So back to our patient. And one thing I found is that sutures can slip, so if you tie some knots laterally, that avoids that. So here we are, the medial. Here's the final repair construct. Here it is at the articular margin. I go in and cut the biceps at the end of the case. And here's our patient 3.5 months out for a left repair. I do some adjustments, so you do sometimes play with the sutures to put them exactly where you want, just like I do for a single rows. You can extend this repair, do a double and a single row. This is a infraspinatus. I can't use this tendon, so I'll do my double row technique anteriorly, and then posteriorly I'll place a single row anchor, as you can see here. I'll tie that first, then do my double row approach. Here's the transition between the two, the patient at 4.5 and 6 months out. This is the other case I've been showing throughout. This gentleman is now at 7 months out. There can be complications, re-tears of course, but by doing this technique, you avoid the CHO type 2 tears at the muscle tendon junction by not tearing the knots medially. Anchors can pull out. This is a patient 9 years later. She had a subscap tear. I repaired that and found this anchor on the pre-op MRI. So again, I repaired the subscapularis tear and took out the anchor. It can also happen early. This lady cares for an adult handicapped child. This was her initial repair, and when she came back, it had retorn. And sometimes the bone quality is not as good. Even screw and anchors can pull out. So I used what I thought was a better anchor for this and did a repair. And I was having early on some loose sutures. This is a gentleman. This is his repair and his 4-month post-op follow-up. He came back to me 6 years later for AC arthritis, and I found the sutures were loose. You can pull them out and then do a distal clavicle. In conclusion, a 2-anchor double repair is efficacious and cost-effective. It's all about the number of sutures, not the number of anchors. More medially placed sutures have greater resistance to pull out. Here you can see a large repair and the outcome with knots tied laterally. Oblique side-to-side sutures are of value to simplify the tear, similar to fractures, as you can see in this case. And I like larger lateral screw and anchors to get this type of outcome in our patients. Thank you.
Jonathan, you made a point to say you don't tie medially. Why not? What's the rationale there?
You don't need to. If you're going from one anchor to all the sutures from one anchor or all the sutures to another anchor, you don't have to worry about that. And I don't want to restrict where the tendon is put down by tying it medially. This way it can comfortably come over the entire greater tuberosity.
And then also with the biceps that you show that you learned from Butch, do you release the biceps or you just add it for collagen and you just leave it attached to the labrum?
I'll go back in and release the biceps at the end of the case so I keep it in a more anatomic position.
Okay, you got any questions out there? Oh, Jay.
John, that was a great talk. Can you give us some pearls on how you teach residents and fellows on the lateral row anchors? You'd mentioned the distance there. I've seen sometimes on the posterior lateral row anchor, there are 2 posterior into the cuff and teres minor. What are some pearls you have for getting the lateral row anchors correct?
It's easy to do more anteriorly because you can see the transition at the lateral edge. You're right, further posteriorly, and I try to mark that early on, so before I'm even bringing my tendon over. So if you're doing 2 anchors medially, 2 anchors laterally, the posterior lateral anchor you got to bring further down every time.
It really helps to externally rotate on that back anchor as well. You can avoid that error just by changing arm position.
And you always want to check your angle, before you do it, and that's so make sure that you're in good bone.
Can I ask a crowd question, John?
Sure.
So how many people are using soft body anchors for medial row now? Hard body? It's about 50-50. Why do you not use soft body?
I don't want to depend fully on the cortex. I'd rather have it, fixed as best as I can through. So that's for the medial one. The lateral one, I know they're doing it again. I don't want to depend. My goal is to reduce or eliminate variables, and to me, that's one variable.